Good afternoon, everyone. We're going to get started shortly. We're just going to wait a couple more minutes because there's still people coming in to the session. Okay, we'll start in 1 minute. If everyone can just put themselves on mute, that would be really helpful, please. Okay, we're going to start. So good afternoon, everyone, and welcome to this webinar. So my name's Camilla, and I'm consultant midwife at East Midlands Ambulance Service and one of the lead midwives at London Ambulance Service. And I'm joined by lots of amazing colleagues who you're going to meet throughout this webinar. So just in terms of setting the scene, so this webinar is for ambulance clinicians who use JRCALC guidelines. So if you're joining and you're not an ambulance clinician who uses JRCALC guidelines, you're welcome to stay, but just note that this content might not be relevant to you. So we just want you to be aware of your well-being throughout this webinar. We realise that maternity cases can touch you personally or professionally, and this webinar might bring up particular things that you've been to or you've experienced in your personal or professional life. So please be aware of your well-being, and feel free to leave the webinar at any point, and also to contact one of us afterwards if you would like to discuss anything. We will be delivering content on all of the updates that have happened in JRCALC guidelines for in the last year. And slightly before that. So what you'll notice is that there's been lots of updates to maternity and newborn care guidance over the last 3 years, and we've now completed all the updates. So we're running this webinar due to brilliant feedback from the last one that we ran in 2024, where we gave a national update to all ambulance clinicians. So we want you to take note of any learning that you have from this webinar and share it widely amongst your teams and across your regions, because we realise that not everyone's been able to attend today, but we will be recording this webinar, and it will be available on our national YouTube channel at the end of today. So we will put up that at the end of the webinar, how to access the YouTube channel. You'll notice that the chat is not open for this webinar, and that's just so that we don't distract the speakers as they're presenting, but the Q&A function is open. So please use the Q&A at the top of your screen to put in any questions for the speakers, and we're going to have a good session at the end of the webinar to answer all of your questions. We will be using the word woman to describe the person that's giving birth, or mother. We do understand that not everyone will identify in this way. So please use the relevant language when you are talking to your patients. We will do introductions as we go through with the other speakers, and you will get a certificate for attending today, but please bear with us while we do that, because there are several hundred of you on this call. And just to say that this webinar is going to cover national guidelines in terms of JRCALC. There will be regional nuances, and you will need to find those out yourselves because the presentations today are based on national guidelines. So what we're going to cover is the wording updates. You'll have a presentation on shoulder dystocia, preeclampsia and eclampsia, cardiac arrest in pregnancy and newborn life support. And we do realise that there have been other guidelines updates before that, but they are available on another recording on our YouTube channel from before. What we have tried to do is make the guidelines purely about the management that would be required in the different situations. So across all of the maternity and newborn care guidelines, we have stripped them back and taken out bits that make them more like a textbook. And we have really concentrated on the management. We've also updated all of the algorithms, and what we would urge you to do is in the heat of the moment to use the algorithm rather than looking at the guideline or being expected to look at the guideline, and get the algorithm out on scene and use it like a checklist. So one thing that we have done is update the name of the imminent birth guideline to labour and imminent birth. So this is following a few incidents around the country where we have gone to women that haven't been in established labour, or they're clearly not imminently birthing, but they are having contractions. And in those cases, what has happened is often the crew has sought advice from a midwife, and a midwife has spoken to the woman, and then this has led to a non-conveyance. So in the imminent birth guideline, or now called labour and imminent birth guideline, it clearly states that if a woman is having contractions, then the ambulance service does need to convey her to hospital. And the reason for that is because we are not able to do fetal monitoring and determine whether the baby is well or not. So that's just a reminder about that and an update on that wording. We've also updated the page per age for newborns. And the parameters that we have there are now in line with NEWT 2. So this is a chart that was made for the hospital setting for postnatal wards by BAPM, the British Association of Perinatal Medicine. However, it is the only evidence that we have at the moment in terms of using the correct parameters for assessing babies and what's normal. So we have used those parameters on the page per age part of JRCALC for newborns. We've also added temperature, and Dawn and Rob will go over later why that is so important in terms of the fact that we now have the appropriate parameters for temperature on page per age. And finally, we would never do this presentation without mentioning the pre-hospital maternity decision tool. So just a reminder, really, because this has been out since 2024 now, and ambulance services are now digitising it into the electronic patient record so that it's universally used. But just a reminder of where it came from. So the parameters that are on the decision tool came from the 4Ps study, which is essentially a study that looked at the population data for women during and following pregnancy at different stages to understand what are the correct parameters in pregnancy and postnatally. So we've used those parameters and put them into the decision tool, and you'll know that there's lots of other red flags and amber flags as you go down the tool. There's just a screenshot here of the first part. So this tool has been adapted for the pre-hospital setting, and you can read more about the development of it in this paper. But what we really want to highlight is the fact that this needs to be used every single time you're attending any woman, any patient that is pregnant or suspected to be pregnant, or has recently been pregnant within the last 4 weeks. So we need to use it whether the case that we're going to is an obstetric presentation or a non-obstetric presentation where she just happens to be pregnant or happens to have been pregnant within the last 4 weeks, and you're going for another reason. We need to be using these parameters. And the reason for that is because we may miss deterioration as a result of the physiological changes that happen in pregnancy and postnatally. I'm now going to hand over to Bethan, who is from the Welsh specialist clinician in the Welsh ambulance service, and Steph Pearce, who is education manager and patient safety midwife in South Central Ambulance Service. Thank you.
Thanks, Cam. If we go next slide, please. Perfect. So as Cam said, we are just going to go over the main changes that have happened to the shoulder dystocia guideline. This is the algorithm of shoulder dystocia. I'm going to highlight what the changes are, and then as we go through the presentation, we will go into them in more depth. So on the left-hand side there, you can see a screenshot of the really clear new algorithm that exists with the instructions and the pictures. One of the main changes is the new diagnosis of shoulder dystocia. So there's a slightly new diagnosis that is very clearly on the front of it. Apologies, Cam, the presentation has disappeared for me. Oh, there you go. The guidance has now set out the manoeuvres into 4 really clear separate manoeuvres, along with the inclusion of a picture to show you what you should be doing, along with the instructions that are next to it. The suprapubic pressure instructions have changed slightly, and we will cover that in more detail throughout this presentation. There is now the inclusion of really clear guidance if you are a lone worker. So if you're the only responder on scene and it is just the pregnant patient with you, there are no bystanders, you've got your own clear instructions of what is appropriate to do in that situation. And there is now really clear guidance on the expectation on extrication and conveyance with these patients. Next slide, please. So what is a shoulder dystocia? We just want to point out firstly that shoulder dystocia is quite a rare event. It is not expected to happen with every birth at all. But what we are talking about is the anterior shoulder of that baby getting stuck on the pubic symphysis. As you can see in that picture there, that top shoulder of that baby is stuck on the mother's pubic bone. And what we need to do with shoulder dystocia to solve the problem is either change the shape of the pelvis so that the shoulder can slip underneath the pubic bone, or physically push the shoulder down, decrease the diameter of the shoulder externally. Next slide, please. Oh, there is also less commonly the possibility that it is the posterior shoulder that can get stuck. There is no way of distinguishing between the two. Your treatment plan is going to be exactly the same, and Beckham will start to take you through those manoeuvres now on the next slide.
Thanks, Steph. So we're just going to go through the algorithm now. So starting at the top of the algorithm, the first thing that we're doing is noting the time that the baby's head is born. So at this point, we could still be on the imminent birth and labour guideline. It's really important at this point that we note the time of the baby's head, because when we convey baby and mum in, the obstetric and neonatal unit will want to know the time between the head and the shoulders being born, just thinking about the best ongoing care plan for this baby. If the body of the baby is not born with the next contraction with maternal push-in, then this is when we diagnose a shoulder dystocia. So just remember that when we are diagnosing a shoulder dystocia, we have to be communicating this to the woman and her family, as well as the team if there is more than one of you there. So the next part of the algorithm is thinking about more help. As Cam's already covered at the beginning, this is going to be one of those local nuances that's local to your service and what that looks like for you. But just think about when you are requesting senior clinical support at scene, we are potentially going to be preparing for a newborn life support, as this is an hypoxic event for the baby and is also an increased risk of a postpartum hemorrhage after the baby is born for mother. So ensure that when more staff are arriving at the scene, that this emergency is declared so that everyone knows what they are dealing with when arriving on scene. If there is enough staff available at this point, it's really good practice to allocate a member of the team to explain the actions and reasons to the mother and the parents. So next point is we need to discourage push-in. So as Steph has already explained, this is a bone-on-bone problem. So if we allow the mother to keep on pushing, we're just going to be further impacting that baby's shoulder. We can use Entonox to support discouraging push-in. So getting mum to take nice big deep breaths on the Entonox can help sort of alleviate that urge to push. We've added a section as Steph said, for lone workers in the bottom of the guidance. So this would be if there was only one staff member on scene and there was no bystander help. So the guidance just outlines some explanation of what to do during this time. So the clinician can alternate between manoeuvres, McRoberts and all fours position, which I'll explain a little bit more about as we go through. But it says really clearly in the guidance that bystanders can support with a woman's legs for the McRoberts position, but axial traction should be performed by the clinician at scene. Next slide, please. So the McRoberts position. So this is a simple, rapid and effective intervention. So this will resolve the majority of shoulder dystortions when performed correctly. So to do this correctly, what we need to do is make sure the woman is lying completely flat. So this would be no pillows, blankets, or anything behind her head or back. And this is to ensure that when we do the McRoberts manoeuvre, that we're opening the pelvis to its widest diameter to allow for the shoulder to pass under the pubic arch. So simultaneously, to lie in the woman flat, we're then going to hyperflex the thighs towards the maternal abdomen. So the legs should be bent at the knees, but ensuring that the legs remain parallel to the abdomen. So we're not going to be abducting the legs at this point. Simultaneously, place hands on either side of the baby's head, and we're going to apply gentle axial traction. So axial traction is keeping the baby's head in line with its own spine, and we're going to do this for up to 30 seconds. It's really important at this time that we do not pull downwards or twist the baby's neck, as this can increase brachial plexus injuries in the baby, which is a significant fetal complication, which is caused by the downwards action performed on baby's neck. So if the baby is not completely burst during the McRoberts manoeuvre, we're then going to move on to the suprapubic pressure manoeuvre. So the last manoeuvre was open up the pelvis so that the shoulder could pass under the pubic arch. What we're trying to do with this manoeuvre is we're trying to reduce the diameter of the baby's shoulders. So again, allowing for the shoulder to pass through the pubic arch. So the woman should remain in the McRoberts position. So we've still got that widened pelvic diameter, and we're still continuing to discourage pushing. And then we're going to use a CPR grip and position the hands on the woman's abdomen. So just above the maternal pelvic bone, which is really important because we need to ensure that the CPR grip is on top of the baby's shoulders to reduce the diameter and dislodge the shoulder from under the maternal pelvic bone. So while our hands are positioned there, we're then going to apply downwards pressure towards the floor. And this is going to be continuous pressure for up to 30 seconds. And again, simultaneously applying gentle axial traction. So gentle axial traction throughout these manoeuvres, the aim of that is just to feel and support the birth if the shoulder is dislodged. Next slide, please. And back over to Steph.
Thanks, Bethan. So manoeuvre 3 is very similar to manoeuvre 2 that Bethan was just describing. So you've got exactly the same people, I suggest, in the same position. So you've got one person supporting each leg, so McRoberts. You've got the same person doing axial traction and the same person applying that suprapubic pressure. The only difference with this one being is that that pressure is going to be kind of intermittent in that rocking motion to see if we can almost nudge that shoulder underneath that pubic bone. You can see from the picture there that there's quite a lot of people in quite close proximity to this patient. So communication throughout this is super important. If one of those people that's kind of supporting the leg can have that eye contact and the communication with the patient during this time, it's really going to help that patient in terms of like processing what's happening. Okay, so again, that maneuver is up to 30 seconds. If before 30 seconds you think this process is futile, it's not working, I've got complete there's no movement with this whatsoever, you can move on to the next maneuver before 30 seconds, but it is each maneuver is a maximum of 30 seconds. This is a time critical issue. There is risk of hypoxia to the baby, so we want to keep making sure it's a quick process. So if we've completed maneuver 3, we've done up to 30 seconds, the baby is still stuck, we're going to move on to maneuver 4, which is the all 4 position. So super simple, it is supporting the woman into an all-fours position from that previous McRoberts position. Okay, so there is no need to support the baby's heads during the movement from being a McRoberts background onto the all-fours position, and as much movement as possible kind of in terms of the woman's pelvis is going to help try and release that shoulder. If the patient delivered on all fours initially, it doesn't mean that you've already used up this position, so you absolutely can go back to all fours. If she delivered the head on all fours, then we declared a shoulder dystocia. She's going to have gone onto her back from McRoberts, do maneuver 1, 2, and 3, and then we're going to put her back onto all fours. We've changed where the gravity is. We've hopefully moved the pelvis to help try and free that shoulder, and then someone is going to again do that gentle axial traction in this new position to see if there is movement and delivery of that baby. Next slide, please, Cam. Perfect. So the arrow after maneuver 4 will take you down to the box that says extrication and conveyance. We've included it on the algorithm just to really show the importance of you try each maneuver once, maximum of 30 seconds. If it doesn't work, we need to convey urgently to the nearest maternity unit so that we can go to somewhere else that has more help, more scope of practice, and potentially different maneuvers that we can do. So the recommendation for extrication and conveyance is to walk the woman to the ambulance with a towel between her legs, anticipating birth at all times. We want you to walk the woman to the ambulance because walking will help increase the movement of that pelvis, which again is going to try and release that shoulder. That really shows why it's important that we have a towel or very similar between the patient's legs. And I'd probably recommend that it is ambulance crew that are holding that towel either side, because if the baby does release and deliver during this time, we need people to be able to have enough support on the towel to catch a baby with however much that baby weighs. Okay, the towel will also help kind of maintain the patient's modesty as well during transportation, and especially things like if there's stairs you need to go down, we'd really recommend kind of that side walking down the stairs to really try and emphasize the movement of the patient's pelvis to try and free that shoulder. Once in the back of the ambulance, we are recommended to convey the patient in that lateral position, so left or right, it doesn't matter which side, but completely on their side, using pillows and blankets between the woman's legs, because the head will still be between the legs. So we want to try and keep that top leg off of the baby's head with whatever we can find to kind of pack between the patient's legs. Mum needs to be completely strapped in on the stretcher, as well as ambulance clinicians strapped in the back of the ambulance. And we are conveying urgently in time critical manner to the nearest consultant-led obstetric unit with early pre-alert. The early pre-alert is a super important aspect of shoulder dystocia, because what you want is for a team to meet you outside that hospital so that they can do further maneuvers and further procedures as quickly as possible to deliver that baby. So getting that really clear, succinct pre-alert in with an ETA and making sure you know where you're going to so that the team are in the right place to meet you is super important. At the bottom of the algorithm, it really clearly says that ambulance clinicians would not be expected to perform any maneuvers en route to hospital. The patient has to be strapped in, the clinician needs to be strapped in. You cannot perform any effective maneuvers in this lateral position whilst being strapped in, so there is no need to repeat or perform any of those 4 maneuvers whilst in transit to the hospital. Next slide, please. And back to Bethan.
Thanks, Steph. So throughout the UK Leeds group, we deliver maternity training quite a lot in our ambulance services, and we commonly get asked the same questions. So we thought it may be useful to add a frequently asked questions slide. So there's no inclusion on the JRCALC guidance for internal manoeuvres, and the reason behind that is as there is no national mandated maternity training provided yearly to update staff. The national guidance doesn't contain the national guidance doesn't contain instructions on how to do those internal manoeuvres. However, we also appreciate that some local services do provide that training, and their staff are able to do internal manoeuvres. So please just follow your local policy for that. So the use of axial traction to diagnose shoulder dystocia. So if any staff are working closely with midwives or obstetricians, then their guidance is that they use axial traction on on a contraction, well, maternal effort to diagnose shoulder dystocia. And the reason that that isn't in JRCALC is because this needs to align with the imminent birth guideline. And if we take ourselves back to the imminent birth guideline, our clinicians are just there with their hands poised, awaiting the birth of this baby. So therefore, the time critical emergency of shoulder dystocia, we diagnose off one contraction where there's been maternal effort. And bystanders for Mac Roberts. So absolutely, if you're a lone worker or a crew and you need another set of hands, so we would instruct one person on each leg to get that effective Mac Roberts position, and bystanders can certainly be used for this. So just like any other emergency, a dynamic risk assessment should be done, and if you feel that bystanders can add anything to the care of that mother and baby, then we absolutely support this. There is a little caveat within the shoulder dystocia guideline that ambulance clinician should be doing the axial traction, but we can ask bystanders to do other manoeuvres. Next slide, please, Cam.
So these QR codes here are from the JRCALC, the guideline, not the algorithm. So within the main guideline, there are actually 2 links to a full run-through video of the management of shoulder dystocia. So the left-hand QR code will take you to the run-through if you've got a crew on scene, so multiple people, and the right-hand link will take you to the video of a run-through of the situation if you're a lone worker. So just repeating those manoeuvres 1, 4, 1 and 4 until help arrives. So if you wanted to revise this at all or kind of have a visual representation of what me and Bethan have just talked through, please feel free to access these via the QR code or access your JRCALC at a later date, and they are within the main guideline for your viewing and for your access whenever you feel like you need it.
And we'd really appreciate your feedback on what you think of having these videos in the guideline, if you think that that supports your practice and if that's something we can do more of. And a massive thank you to the staff that were involved in recording the videos, and also JRCALC for supporting the updates of all of these guidelines, but pulling the videos together.
Thank you so much, you guys, and thank you for your tireless work on the shoulder dystocia guideline as well. So now we're going over to Dawn Kerslake and Rob Tinian. So Dawn is consultant midwife at South East Coast Ambulance Service, and Rob Tinian is consultant neonatologist in Newcastle.
Thank you very much, Cam. So good afternoon, everybody. Can I have the next slide, please, Cam? Whilst Cam's getting that up, I just want to take this opportunity to square away a question that we regularly get asked on the NLS course, which is at what point do we swap from doing the NLS algorithm to the paediatric algorithm? So this decision has been made that that will be 24 hours of age. So if the baby is under 24 hours, you can do NLS, and if the baby is over 24 hours, you'll consider using paediatric. If there's a midwife on scene, she will likely only know NLS and will therefore NLS until you may take over or work collectively under direction. So just as an FYI. Okay, so what we're going to be talking about? We're going to be talking about thermal care, assessment at birth, airway and oxygen, and the new out-of-hospital NLS algorithm. Next slide, please, Cam. So what's really important to note when we talk about thermal care is that newborn babies are unable to produce or conserve heat. And I just want you to think about that for a moment. So they are basically only as warm as we make them. So they can't produce heat and they can't conserve heat. So that's a huge responsibility for us. So with that in mind, I want to think about the environment. I want to think about where you are right now, trying to manage this situation. Do you need to close windows and doors? Do you need to think about getting warm towels? You might ask a partner to put them in a tumble dryer or place them on a radiator. And whereabouts have you done your resus dump? So preferably, we're going to do that on a coffee table or a dining room table. If we're upstairs, it's less of a problem. But if we're downstairs, we really don't want to put the baby on the floor. And I know some healthcare professionals set up a resus dump on the floor on a changing mat. That's the coldest area in the room. And every time a colleague comes in, they will get a bit of a draft wafting over them every time that door's open. So just be conscious of that. I'm really hopeful that most of you in your maternity packs have 2 towels. And if you don't, this is time to lobby your services to ask for a drying towel and a wrapping towel. So if you imagine, I mean, why is this so important? If you imagine that you are in the shower right now, having a lovely warm shower, and you step out of the shower and I open all the doors and windows and I don't give you a towel, you're going to get cold really quickly, and that's the equivalent of being born. So the drying towel, we dry and we get rid, because if we stay in a damp towel, we stay really cold. And then we're going to wrap our baby in a nice warm towel. Now, it might be at this point that you need to think about what heat you're going to introduce as well. So if the baby's very well, you can keep the baby skin to skin with mum and cover them both with your warm towel, making sure that you keep the airway to the side. If, however, you've got concerns about your baby, and we'll talk about the assessment in a second, then you might choose to take the baby over to a heated mattress, a heated thermal mattress, and we'll talk a little more about those in a second as well. I think it's a good time to mention that every degree below 36.5 that a newborn baby's temperature drops, their mortality increases by 28%, and that's in a term baby. So a preterm baby, mortality will be even higher. So newborns can lose a degree of heat every minute without thermal care. So again, just keep that borne in mind. We know, don't we, that cold babies can't be resuscitated. So you might be the best resuscitator, for want of a better term, but if your baby's not warm, your efforts are going to be futile. And then finally, I just want to talk about the altered approach for babies under 32 weeks. So up until now, we've talked about drying a baby and keeping them warm. But in a baby under 32 weeks, we're going to do the opposite. We're going to keep them wet and we're going to put them in a plastic bag. And the reason for that is that we want to stop heat loss from evaporation. So the bag traps that humidity to halt evaporation. If somebody's already dried your baby, then you don't need to put moisture in a bag. You can put the baby in the bag dry and then repeat as you would. Keep the baby wrapped, put them on a heated mattress, etc., etc. Next slide, please, Cam. And if you could click again, thank you very much. Just before we talk about next actions, I just want to share with you a job that we went to recently, because I think it highlights the point really nicely. We recently went to a job where baby had been born for 25 minutes. It was a BBA, and there was somebody walking around.
Bus working now.
If somebody could go on mute, that would be great. Lovely, thank you. A partner was okay. I need somebody to go on mute. I can hear you.
I'll sort it out, Dawn. You carry on and I'll look through for her.
Thank you. So partner was walking around with baby skin to skin on their chest, but the baby was completely exposed. So they'd been walking around for 25 minutes. Although the baby had been getting the heat from dad externally or on the back of the baby, there was no heat. So we arrive on scene and the mum is very sick and we need to extricate very quickly. And the team asked dad to quickly dress the baby, which they did, and they left to hospital. When they got to hospital, the focus was very much on mum, but the neonatal team came and took baby, and the baby's temperature was unrecordable because it was so low. So I think the point I'm trying to make here, just circling back slightly, is that if your baby's already cold and you dress it, it stays cold. You basically keep it in the fridge, because remember, babies can't produce heat. So the learning we had from that is the importance of warming your baby before you dress them. Okay, let's move on to assessment at birth. We get asked an awful lot, at what point do we clamp and cut the cord? And the guidance says 60 seconds. But I want you to not have to worry about that 60 seconds, because I want you to focus more on what you're going to do initially or immediately. So I'll deliver a baby, I'll put it straight onto mum, and I'll start stimulating and drying immediately. And to really thoroughly stimulate and dry a baby, it takes 60 seconds plus. So I kind of don't worry about that 60 seconds. If I know that I've followed the algorithm, which is drying and stimulating, I know after that point, if I need to separate mum and baby, that 60 seconds has elapsed. So where possible, we'd like to keep mum and baby cord attached for longer. So we talk about delayed cord clamping. And in our guidance, we've said a minimum of 60 seconds or until the cord is white if the baby is well. And the reason for that is that we know there's an extra surge of blood from the placenta if we wait until the cord goes white. So if you can possibly do that if the baby's well, that's fantastic. If the baby is not well and you're concerned about the baby, then of course 60 seconds, clamp and cut, and take the baby over to your resus area. So we're just trying to help this baby transition from placental to pulmonary respiration. Next slide, please, Cam. And just before I hand over to Rob, it's also really important, whilst we've got this webinar, just to remind everybody that all babies need warmth, not just preterms. So if your services have been provided with heated mattresses and other kit to help keep your baby warm, please use it for your newborns as well. This isn't just for tiny babies, this is for all newborn babies. Thank you, Rob. Hand over to you.
Thanks, Dawn. So as Dawn's already alluded to, there's potentially a bit of cord intact time. And during that time, you want to find out how the baby's doing. And previously, people went through colour, tone, breathing, and heart rate as the key metrics for this. But it's been realised that really the only thing that matters in terms of guiding your resuscitation or stabilisation of babies is the heart rate. And so knowing from the front end whether the baby is breathing and whether the heart rate is very slow, or fast is really the key start point for any ongoing work down the algorithm. Colour itself has been de-emphasised. We used to talk about pink babies and blue babies and white babies, and the truth of the matter is that as a proxy for cyanosis, as all clinicians in any setting are absolutely pants at working out how saturated or not a baby is by looking at its colour. And MNSI have quite rightly pointed out that as soon as you add other skin tones other than sort of no melanin at all, the ability to be able to see the cyanosis decreases further. So really colour plays little part at all in the initial assessment of the newborn anymore. Tone is something that can be noted at the point that the baby is born, because if you have a baby who has very little tone, is very floppy, you are likely to then be able or to need to get on and do things with the baby, and it may be that actually support of the airway is going to be pretty high up your list of things to do. So from that point of view, note it, but as you then move down the algorithm, listening to the heart rate using a stethoscope is your gold standard for seeing how your impact is going. And obviously if the baby's not breathing but you are doing things for the baby in terms of breathing support, you need to know whether the chest is rising. Next slide, please. Oxygen is something that has been kind of streamlined for the guidelines coming in 2026. So the first thing just to note is when you look at the target saturations, we've gone from a threshold to cross to a range that's acceptable. And that's based on new data that came out of Australia, looking at cohorts which had larger numbers of preterm babies in them. So the 3, 5 and 10 minute metrics that you have there are ones which are for all gestations. They're not just for term babies. And what we know is that if you can measure the saturations, then that's great, because it allows us to think about how much oxygen we're giving to the babies at any given time. And so the last box of those three talks about titrating to target saturations when you've got a trace. But in the pre-hospital environment, you're somewhat limited with the kit that you're likely to be carrying. And so really in terms of a start point, we still say that for babies that are more than 32 weeks, you should be starting in air. And the ILCOR, which is the International Liaison Committee on Resuscitation, is very clear that it's one of the few things they actually recommend against is adding in oxygen to term babies in terms of your start point. However, once you find yourself in front of a baby that is 32 weeks or less, this is where there is some discussion, which I'll come on to in a second. But the problem is that in hospital, where I'm quite lucky, I can add in a certain amount of oxygen, and so starting in 30% or more is fine. In the pre-hospital environment, you can't really do that. So what we've settled on is something straightforward, which is if you're less than 32 weeks, add oxygen to your bag valve mask and crack on. Similarly, if you find yourself in front of a term baby and you've worked all the way down the algorithm and you're thinking about adding in 100% oxygen, or you're thinking about doing chest compressions, I should say, it's the point where pragmatically adding in 100% oxygen becomes sensible. And you'll notice on the algorithm, I'm sure you've all seen it, that at that point as well, a step to secure the airway to free up hands is also useful. Next step, please, Cam. So the oxygen trials that are informing the use of oxygen are in the process of producing hopefully some answers towards where we need to go with oxygen. So the one on the bottom left there is the Torpedo 3060, which looked at 60% versus 30% oxygen. And the high-low, which is the one above it, is a similar design. And the importance here is that we worried for a long time about giving oxygen to preterms in terms of impact on their respiratory function later on with inflammation and also retinopathy of prematurity. But what the Torpedo trial has shown, and what hopefully the high-low trial will show, is that higher amounts of oxygen don't really affect outcome, but what they do is they reduce the chance of you needing to do things like they reduce the chance of you needing to do things like CPR. There are some trials in the planning stage which are going to go back and look at use of oxygen during the resuscitation and stabilization of term babies, but they're not out. So for term babies, still no oxygen is the way ahead, starting there. Next slide, please. So on your JRCALC app you have in your guidance, you will have this version of the newborn life support algorithm. So RCUK published two. They publish a hospital version and an out-of-hospital version. And this is one that has been refined and adapted to apply to pre-hospital clinicians, ambulance clinicians working in the community. And what it really does is it acknowledges the fact that you guys are in a setting where you don't have access to the kit that we do in hospital. You have a hostile environment in which to work. And for you, unlike me, I've got 18 meters to walk between delivery suite and the neonatal intensive care unit. You might have 18 miles to move a patient. So conveyance is a huge part of the work that you do, and the algorithm is there to try and help that. Just looking through the algorithm, it emphasizes delayed cord clamping wherever is possible and safe to do so. As you step down it, the other key thing is making sure that you have chest rise, so you see the chest moving as you are intervening and giving breaths to the baby. And on that note, I just want to point out that the two-person airway support is something that across all of the NLS guidance is being emphasized. So we know that it is probably the most effective maneuver to open the airway of a newborn baby with the head held in a neutral position. And the sooner it's done, the better in that respect. It's something that actually is really quite helpful because unfortunately, not all supraglottic airways, iGels or otherwise, will fit all babies. So it's something that will get you out of trouble, especially with the preterm babies. So if you have resource on scene, if you have enough people, if you have the expertise, then it's really important as quickly as possible to go to the two-person technique if you're needing to do that. All the way through the newborn life support, there is an emphasis on measuring things and correcting them. So Dawn's already talked to you about measuring temperature. That lets you then intervene and hopefully improve temperature. Saturations I've mentioned, it's worth measuring those. And glucose at the end is also worth measuring. One thing we sometimes get asked about is how you might monitor heart rate when conveying a baby to hospital or on scene. And all I'm going to ask you as a neonatologist is please don't ever use the defib pads. They are huge and they can cause massive amounts of damage, and your pulse oximeter will work, or if you've got the little dots that you can put on the chest, that's fine too, but no defib pads, please, if that's okay. So the algorithm, as you see it there, is a very nicely distilled ambulance-focused version of the out-of-hospital NLS guideline, and it's one that I would definitely commend to you. So on scene, that bit of paper is the thing that will get you out of trouble. Thanks, Cam.
Thank you so much, Rob and Dawn, for that brilliant presentation. So now we're going on to cardiac arrest in pregnancy, and this is going to be presented by Stacey Cudden, who's lead midwife at London Ambulance Service, and Steve McGee, who is consultant paramedic at the Welsh Ambulance Service.
Thanks, Cam. Thanks, everyone. So, as Cam said, we are going to spend the next few minutes talking through the changes to the guideline with reference to cardiac arrest in pregnancy. Next slide, please, Cam. So first of all, we just wanted to make sure and clearly direct you as to where you'll find this new guidance, and particularly the algorithm. So in the event you have to attend anything like this, it's just to point out that you'll find the algorithm and the guideline sits within the maternity care tiles, so not necessarily under the resuscitation tiles that you might find with the algorithm. So please make sure you familiarise yourself that it sits in that place as far as the guidance and the algorithm. Next slide, please, Cam. So here it is. Here is the algorithm that we're going to spend the next few minutes talking through. So you'll see, if you first look at it, you might think it looks very familiar, if not almost exactly the same as the standard adult ALS algorithm. And there are mainly a lot of similarities. But like I said, we're going to spend this session today talking about the nuances associated with a cardiac arrest in a pregnant patient. So we're going to work through the steps that have been particularly highlighted here so that there's an understanding of where things remain exactly the same as any other adult patient that you would see in cardiac arrest, but the slight differences that you'd have to adapt to, particularly when it comes to calling for help a little bit earlier, and a couple of practical adaptations that you have to make for this pregnant patient. Thanks, Cam. Next slide. And Steve. Oh,
thank you. So as you look through the new guidance, it's broken down into chapters, and probably the first one you'll come across, minus the introduction, is assessing gestation. When we're dealing with cardiac arrest in pregnancy, obviously the first thing we need to understand is the mother pregnant, is the woman pregnant. The next most important thing is what is the gestation, because this will affect the way we manage the arrest. So within the guidance, there's two sort of strands: under 20 weeks gestation and over 20 weeks gestation. So to ascertain if the woman's under 20 weeks of gestation, we look at fundal height in relation to the umbilicus. If it's below the umbilicus, then it's less than 20 weeks, or if it's above or in line, then it's over 20 weeks. You can ask members of the public, or not members of the public, sorry, family members, just to gather this history, but it's really important. If the woman is under 20 weeks gestation, then our management remains absolutely the same. We don't have to make any modifications to our practice. We just utilize the standard ALS protocols that we would with any normal adult in cardiac arrest. Although there is a rider to that, as is written on the screen, it's worth considering. We need to have a high index of suspicion. With any woman of childbearing age, we need to consider additional reversible causes, such as a VTE or ectopic pregnancy, because this could be a cause of a cardiac arrest. If the woman is over 20 weeks gestation, then we will have to adopt a modified approach, and this is the whole purpose of this guidance of cardiac arrest in pregnancy. And one of the biggest ones being is the displacement of the gravid uterus. What we need to do is alleviate aortocabal compression, which is the gravid uterus compresses on the inferior vena cava, and it can cause a reduction in the blood flow back to the heart. So we'll look into that later. There's a big section on it, but that is the main rationale between the adaptations we need to apply. Next slide, please. So the next section, obviously in the previous iterations of JRCALC, all of the cardiac arrest in pregnancy was within the specialist circumstances, and it was really kind of hard to find when there are a number of modifications that need to be adopted or considerations that need to be addressed when dealing with cardiac arrest in pregnancy. So within the guidance, we've broken it down into a nice reference table, and we've followed the ABC approach, because it's what we're used to within practice. It's how we follow. That's how our thought processes work, and this is the process we follow when assessing and addressing. So we've looked at the anatomical or physiological differences within pregnancy, and then what the considerations are for ALS. So not only are we giving you the problems, we're highlighting what the answers could be as well. Again, we've included as many as we can. Obviously, there are going to be exceptional circumstances that's not within this guidance, but it's always a high index of suspicion on the areas we need to look at and how we can address them. So I won't read through them all. They're all in there, and you know the adaptations and the ways to address it are all listed appropriately. It's worth noting as well, at the bottom of this section, we've included a an additional section to the reversible causes. So within a traditional ALS algorithm, we have the 4 H's and the 4 T's, which are reversible causes. We've included something which is the 4 P's, and we'll cover that on, I think, the next but one slide. Next slide, please.
Thanks, Steve. So if we go back to the algorithm that was on the first slide that we showed you, we highlighted the importance of early escalation. So we'd very much encourage you to familiarise yourself with what your enhanced care team looks like in your service, whether that be a HEMS team or a critical care service with medics. Please familiarise yourself and where they are, so that how would they find out that you were attending a woman in cardiac arrest that was pregnant? It's critical that as well as letting them know and making sure that decision making is being made as far as how quickly they can get to scene, whether or not you need to consider a rendezvous point, or whether actually it's better for that patient for ALS to be established and for you to make your way to the nearest emergency department. So that will require really clear communication, which in a very stressful environment needs to be clear and delegated as soon as possible. The reason, and we're going to talk in a little bit more detail, but the reason why the enhanced care team will be dispatched and as early as possible is with a view to performing a resuscitative hysterotomy, either on scene or at a rendezvous point that would be decided by the team. So there is really a clear reason as to why they are coming, and that's to perform this procedure. And we're going to talk about it in a little bit more detail, but it's high up there as far as soon as you understand that you're going to a maternal cardiac arrest, you want to make sure that our enhanced care team is aware and are making a plan to attend or a meeting point or to the emergency department. Next slide, please.
Oh, thank you. So, as I mentioned about manual uterine displacement, so in cardiac arrest during pregnancy, when it's above 20 weeks gestation, the most critical intervention we can do is manual uterine displacement. As I said earlier, this is to relieve the aortocaval compression caused by the gravid uterus compressing the inferior vena cava, and that inhibits the blood flow during our resuscitation episode. Manual uterine displacement involves physically using 2 hands to push the gravid uterus whilst the mother is supine to the left side. Well, it depends either, but normally left side, and it's just to improve the quality of venous return. Historically, there was a recommended practice of putting a left lateral tilt or putting an incline, but that's been no longer advised purely because it impedes the effectiveness of CPR, of compressions, because the woman's not on her back and not receiving good quality compressions. So having the incline or the left lateral tilt does affect compression quality, and obviously what we're aiming for is high quality compressions. Manual uterine displacement is as important as high quality CPR. It's the same physiological benefit, and without it, quality of compressions will be reduced without manual uterine displacement. And I think that's it. Yeah, thank you. Next slide, please.
Thanks, Steve. So as Steve alluded to when talking about the physiological adaptations in pregnancy and what needs to take place, is going back to when you're at the point of your algorithm establishing ALS and you're looking at your reversible causes, your 4 H's and 4 T's. The JRCALC has adopted the same approach as the European Resus Council in exploring what is unique to this pregnant patient that might be causing her to be in cardiac arrest, and that's where they have put into the algorithm considering the 4 P's. But it's important to understand that these are really, as far as our pre-hospital clinicians, this is for awareness rather than a reversible cause that can be immediately treated on scene outside of hospital. But it's important as far as the awareness when together as a team you're working your way through reversible causes, what could be causing this, making sure that you've got that in your mind as we head towards hospital where the full multidisciplinary team can help manage this woman. History taking is really important, so any information that we can gather from family on scene is really important about her pregnancy so far, whether she has any underlying conditions, whether she's been managed by an obstetric team or a maternal medicine team. All of those things would be really, really valid and important for someone to be able to speak with the family. Likewise, if she did have handheld notes or you have access to any kind of digital maternity notes, then that would be really helpful. So if we just quickly work our way through the 4 Ps. So first of all is preeclampsia and eclampsia. And this really is about end organ dysfunction associated with severe preeclampsia and eclampsia that can lead to a cardiac arrest. Following on this session that Steve and I have about cardiac pregnancy, you'll have the update about preeclampsia. So I'm not going to tread on any toes there. But it really is, it can be very complex if not managed and can potentially lead to a cardiac arrest. Puerperal sepsis. So unfortunately, sepsis is still one of the leading causes of maternal death. It would need to be considered as far as when you're reviewing the possible causes of her cardiac arrest, and then, you know, suitably handed over with a high if you have got a suspicion of sepsis to the team. So again, this woman can be appropriately treated, antibiotics, inotropes, etc., as far as managing her overwhelming sepsis that's caused a cardiac arrest. So then there's placental and uterine complications. So this could be placental abruption, placenta previa that started to bleed. It could be uterine rupture or inversion. It also includes amniotic fluid embolism. So again, nothing that can necessarily be reversed or managed on scene, but would need to be considered and handed over in hospital so they can appropriately manage this patient. And then lastly is your peripartum cardiomyopathy. So this is a particular heart failure that occurs towards the end of pregnancy or in the months following. And it's diagnosed usually when there's no known identifiable cause of heart failure. It's associated with left ventricular systolic dysfunction and usually is diagnosed when there is an ejection fraction of less than 45%. So again, a very complex patient. If you were to get ROSC on this patient, she would need to be treated for her heart failure as quickly as possible with the multidisciplinary team. As we've already alluded to, as far as your ongoing management of the cardiac arrest with your manual uterine displacement, establishing ALS in the way that's described within the algorithm and the guideline, reviewing your 4Hs and 4Ts is really important. So particularly with a high suspicion for hypovolemia, remembering that with pregnancy and postpartum complications, the blood loss may be actually concealed and not visible immediately when you're on scene or during the cardiac arrest. And then thrombosis. We know that venous thromboembolism is the leading cause of maternal death in the UK. And so we have to have a high suspicion when we're working our way through the causes of this cardiac arrest is has she got a clot that's caused her to go into cardiac arrest. Next slide, please. And then we just go through and just touch on here when we talked about the call for the enhanced care team, and as I've already alluded to, they're going to be attending to do this one particular procedure. We've already talked about the importance of that dispatch, that contact within your control room environment and who dispatches the enhanced care team as far as where it might take place. Whether or not it's making your way to the emergency department, you're going to rendezvous at a particular point, or you're going to wait on scene, establish ALS, have ongoing good ALS ongoing, and then the team arrive on scene. So the primary aim for the resuscitative hysterotomy is to fully relieve aortocaval compression by delivering the baby. It's a cesarean section out of hospital, and they will make the decision there. What's really important that again we've adopted within the guidance as far as critical care enhanced care team services is taken again from the European Resource Council that has put a de-emphasis on the 4 to 5 minute rule that used to exist. It used to talk very much about performing the RH as soon as possible within a window of 4 to 5 minutes. That's now been de-emphasized. Again, thinking very pragmatically and realistically as far as what can be achieved as far as dispatch and time on scene, it is rarely to never within a 4 to 5 minute rule. So the team would make a decision there as far as various different scenarios that they would get a background for before they decide to undertake the resuscitative hysterotomy. So for our pre-hospital clinicians that are likely to be on the call today, this very much is for an awareness of what might occur on scene once the enhanced care team gets on scene and they decide to do the procedure. All members will have to be prepared, and it's highly likely that this will be the first time that the member of the enhanced care team, the doctor that's attending with the enhanced care team, has ever performed such a procedure. So everyone will be probably fairly new to this and never done it before. So again, that pre-briefing, making sure everyone understands what's about to take place. It is a rapid surgical procedure. There'll be knife to skin and there'll be a large incision made very, very quickly. So again, everyone being really mindful and aware. Things like Sharp's injuries, making sure all hands are out the way. You're using a scalpel, it's going to be very, very quick and dirty. The doctor who's performing the surgery has to go through several layers. Once they've made that initial incision, they have to cut through several layers to get to the uterus, where they make the final incision to then start delivering the baby. What's incredibly important, and probably the most important bit for our pre-hospital clinicians that are on today, is as well as being ready and prepping yourself for seeing and witnessing and being part of the resuscitative hysterotomy, is making sure you are ready for NLS. Rob and Dawn have just spoken about all of the updated guidelines. It would be the expectation that there'll be a team of clinicians that would get ready to receive the baby. So make sure you've got your NLS area ready, make sure you've got your algorithm sorted, and be ready to receive that baby. Scene management is going to be critical in this situation. The team will decide as and when the right time is to start moving the woman, to start extricate and convey the mother to hospital, and that might be a different time to when the other team need to transport the baby. So again, scene management is absolutely critical. You need to make sure that you're all on the same page as what hospital you're going to. And then you have to make sure that a clear and early pre-alert is passed, and that is one for each patient, so that you're making the nearest hospital fully aware of what they can expect, and as early as possible, so that they have the time to summons the team down to the emergency department ready and waiting for when you arrive. And I think that is all from us.
Thank you so much, Steve and Stacey, and as well, thank you for your input into the guideline as well. So now it's over to Joanna Gerling and Kerry Wykes. Joanna is consultant obstetrician in London, and Kerry Wykes is specialist midwife at East of England Ambulance Service and also paramedic.
So am I kicking off, Camilla and Kerry? Is that?
Yes, please.
Yeah, good. Okay. Thank you. Thank you for the introduction. Thank you for having me as part of the team. I appreciate, as someone who's hospital based, that my perspective is different, but it's been really helpful to work with everyone developing these guidelines. So I've got 5 minutes, I think, just to try and summarize preeclampsia. So I thought I would just try and go through the things that might be helpful for people who are working in ambulance-based services. So from a maternity perspective, diagnosing preeclampsia probably underpins absolutely everything we do. Our total obsessive measuring blood pressure and dip sticking urine at every point of contact with the pregnant woman is around trying to diagnose preeclampsia. And once we've done that, most units will offer most women inpatient care with a view to timing her birth in a way that maximises the baby's gestation and outcome and minimises any harm to the mother or baby. But not all units will have all their women in hospital with the diagnosis of preeclampsia, and not all women will accept our guidance, as I'm sure you're familiar with. So there will be a group of women in the community with preeclampsia who might, or their family might, make a call to urgent ambulance services. Then there's also that second group of women who might be in the community with preeclampsia, whose condition has developed really aggressively and rapidly between their standard antenatal clinic consultations. And those, in a way, are probably going to be the hardest for you, because they won't have a diagnosis already. Preeclampsia is a pretty poorly understood condition. It does affect around 5 to 10% of all pregnant women. It mostly happens in the 3rd trimester, particularly the end part, but it can happen from 20 weeks onwards. It's typically characterized by high blood pressure, protein in the urine, and a smaller than expected baby. And I appreciate that many of those things are not going to be easy for you to consider to diagnose when you're acutely with the woman. And it seems to come about through some maladaptation of how the placenta develops from about 12 weeks onwards. why one woman might get really aggressive preeclampsia and another doesn't is really not well understood. But it's because it's multi-system, as we heard just briefly from the last speaker, it can really affect any part of the woman. So the neurological symptoms, I think, or presentations are well known. Eclampsia or a generalized seizure is rare. It probably happens in most good-sized maternity units only 2 or 3 times a year. I suspect many ambulance crews have never seen it themselves. It looks like a generalized seizure. Someone else joining the chat, or women can also present with focal stroke type symptoms, or they can be having a stroke through due to the complications of severe hypertension. And from our hospital-based perspective, getting the blood pressure down as quickly as possible is something that's really key. From your perspectives, getting them to the hospital so that we can get on and do that is really important. And any blood pressure over 140/90 in pregnancy, we want to be treating. Women can also present with collapse through other reasons other than through stroke or eclampsia, particularly abruption, bleeding behind the placenta, so acute abdominal pain, collapse, maybe with vaginal bleeding. Women who are collapsed in that way may also have ruptured an intra-abdominal artery, so splenic artery aneurysm rupture is rare, but it's much more common in pregnant preeclamptic women than other groups of women. And then there's a variety of liver and renal involvements that again can make women really unwell and can result in them or their family calling 999. So I guess one of the messages I would say as a hospital-based clinician for those of you who are not hospital-based is just always think about preeclampsia if you've got a woman of childbearing age, particularly if you know she's pregnant. Remember, there can be concealed pregnancies. It masquerades in all sorts of different ways. So as soon as you see high blood pressure or a woman pregnant woman who's unwell, please think preeclampsia, please bring her to us. Please follow the algorithm, which a lot of really good people have done a lot of work on developing. I'm happy to take any questions later, but I think, Kerry, if I hand over to you for the more practical nuts and bolts of what to do.
Thank you so much for that, Joanna. So first of all, we're just going to kind of redirect us back to the maternity decision tool, because as Joanna's pointed out, these patients can present in a numerous different ways. So it's about looking at what we're dealing with at that moment in time, and what we've done with the preeclampsia guidance this time is we've managed to hyperlink the pre-hospital decision tool into it, so you can kind of hopefully flick between the guidance, and it just makes that traversing the algorithm and the guidance much simpler from a user's standpoint. But Joanna's already touched on it. The blood pressure 140/90 to us as pre-hospital clinicians isn't going to stand out. And that's why it's so important that whenever we attend somebody who we suspect to be pregnant or who is pregnant or has had a pregnancy within the past 4 weeks, that we kind of place them within the maternity decision tool and their observations within that maternity decision tool to alert us to those that are going to be more concerning to us. So you'll see within that above 144 specifically will count as a red, and same for above 96 will count as a red, and anything that's red should be kind of minimized on scene time and pre-alerted in hospital. And then those kind of borderline blood pressures, 136/89 up to 144/96, they're still going to need some assessment, but potentially not that pre-alert or the time critical transfer. It's also kind of taken on board all the other symptoms. So we've just tried to make it a little bit easier for people to ascertain, is this something that's normal for pregnancy, or is this something that's going to be a little bit more of a concern for us? So our upper abdominal pain or right upper quadrant pain is fairly common in those developing severe preeclampsia. Headaches that don't go away with paracetamol, visual disturbances, so small flashes in front of their eyes, things like that, and kind of rapidly developing edema. And these are the ones that are most likely to go on and have those eclamptic seizures or those tonic-clonic seizures. So those people where the disease, as Joanna's mentioned, is incredibly aggressive, developed really quickly, and transpired into that pre-hospital tonic-clonic seizure. So if you could go on to the next slide for me, please, Cam. So this is our updated algorithm, and we really made the effort to simplify it as much as possible. We know that the last pre-eclampsia and eclampsia guidance was really quite lengthy, but we wanted to kind of just bring it down to the basics and doing the basics well, because that really is such a huge aspect for us as pre-hospital clinicians. So we need to ascertain, is it a tonic-clonic seizure? And that's what's really nice in one respect about preeclampsia, is it's not focal, it's not vacant, it's none of those kind of presentations. It is a characteristic symmetrical tonic-clonic seizure that we see in these individuals. And then we want to be looking for that early escalation for critical care support, because as Stacey's mentioned previously, in maternal cardiac arrest, there is a risk of arrest with these patients. And as Joanna mentioned, because of that severely high blood pressure, there's also a risk of intracranial bleed as a result of the pressure on the blood vessels or bleeding elsewhere. So we would like that early support on board wherever possible. So with regards to managing the seizures, we haven't added anything. There doesn't need to be anything different. We always place our patients in left lateral or in a lateral position. We manage their airway. We wait for that seizure to self-terminate, and we look where possible, if sensible, to get IV access at that point. But for the most part, those of us that have attended seizures will know trying to get a cannula in a fitting patient is incredibly difficult. So normally just waiting for that seizure to self-terminate. And then being prepared and getting that IV access in is really pertinent. Nice large bore cannula if we can manage it, but it is just about giving that medicine. So anything that we can get would be really beneficial. So we don't give IV fluids to eclamptic patients, so we don't want to be put more than your standard flush. We don't want to be putting anything more through that cannula, and that's because of the renal involvement. The kidneys start shunting and pushing fluid elsewhere, and it ends up in a place that's going to be more problematic than anything else. And then the next thing for us is to look to administer magnesium sulfate. So we know magnesium sulfate isn't carried by all of our ambulance services, but it is carried for the vast majority by our critical care physicians, and it is also sometimes carried by our routine kind of frontline paramedics. And the reason that we have defaulted more to magnesium sulfate is magnesium sulfate is incredibly effective at preventing and managing eclamptic seizures when it's compared with diazepam. So our diazemols, it's a 47% reduction in maternal death when we give magnesium over diazepam, and a 57% reduction in a recurrent seizure. So if diazepam or any benzodiazepines is all that you've got available, we're not going to advise crews against using them, but it's not going to be an effective treatment for this individual. Rapid transportation to the nearest maternity unit with a stabilised patient as best possible, that's pre-alerted in, so the receiving unit are ready to receive that individual, is going to make much more of a difference to her than potentially giving those benzodiazepines. So on magnesium sulfate, I wanted to talk to you a little bit more about that specifically. So I've mentioned obviously why we recommend magnesium over benzodiazepines, but magnesium sulfate is absolutely the first line for the treatment of eclampsia, and that's pre-hospital and within the hospital setting for when it's incredibly severe. It prevents seizures by dilating all the blood vessels, and that includes cerebral vasodilation, and it helps support the blood-brain barrier permeability by just reducing that and stabilizing the cell membranes. So the reason that I wanted to talk about it specifically is often as pre-hospital clinicians, we don't see magnesium given, or we give magnesium in already life-threatening situations. So our refractory rhythms or our life-threatening asthmas. When it's given to a maternity patient, sorry, if you could go on to the next slide for me, please, Cam. I'm just happily talking away about eclampsia there, about magnesium. We give 4 grams, so it's double the dose that's given for asthma and double the dose that's given for refractory rhythms. But often we're going to have a patient who is conscious and conversive with us. We find that those patients who have incredibly severe preeclampsia, who are very worried are going to go on and have a seizure, or have just had a seizure, will be quite cognizant quite quickly. And it's a really scary drug if you've never seen it given or you've never received magnesium. So we want to make sure that we're really adhering to the guidance and adhering to the monograph when we give that.
So we want to be giving it over 5 to 15 minutes, and it is absolutely critical that it is not given any faster than that. This is not a gentle advice over the administration times. It's really, really important. It is not given any faster than 5 minutes. And that's because giving it really quickly can cause AV conduction abnormalities, which eventually, if we're not careful, can lead to cardiac arrest. And we're already in quite a scary situation. We don't particularly need to make that any worse for ourselves or for the patient. But the side effects are quite profound. So if anyone's ever seen magnesium given or to somebody that's quite cognizant, the most common thing that they get is this impending sense of doom, which for us as pre-hospital clinicians often does come before something quite negative, but it is a normal side effect of magnesium and should be hopefully discussed with the patient ahead of time. They get tachycardic, they get flushed as a result of this really massive vasodilation. They often feel their arm burning as the drug is going up their arm. And obviously, because we're not diluting it with further fluids because of their renal problems, that sensation is going to be really quite aggressive at the time. Sometimes they get the feeling like their waters are breaking, or they've got urinary incontinence, again because of that vasodilation. Drop in blood pressure is incredibly common, nausea, vomiting, and some dizziness. And the reason that we want to talk through these is these are incredibly common side effects. As somebody who's seen magnesium given multiple times and probably gives magnesium a few times a week when I'm working in the maternity setting, it is so scary for that patient, and you're often counting them down within those 5 minutes. And I think for us as pre-hospital clinicians who aren't giving this drug regularly, and if we are giving the drug, we're giving it to people who already feel like they're about to die, or if they're in a refractory rhythm, are already in arrest. We've never seen these side effects before, and that's really scary for us as well as pre-hospital clinicians. So having that conversation, taking that extra minute to make sure that you've gone through the monograph really nicely, that you're happy with how it's drawn up, that it isn't going to be administered any faster than it should be, is really, really important for these individuals, just to make sure that they feel safe and secure, and that we feel comfortable and confident so that we're safe to give this medication when it's given. And if we have got critical care teams or advanced care teams with us who are administering this medication, they're potentially going to be focusing on that task. And if we're not administering them, we're going to be supporting the patient through that. So I just kind of wanted to lean on that a little bit more and just mention that a little bit. With regards to our specialist care teams, as we've mentioned in previous discussions all throughout today, it is all about where you are, and is it better to wait, or is it better to rendezvous en route, or is it better to go into the maternity service? But when it comes to severe preeclampsia and eclampsia, getting the patient from wherever they are into the maternity setting as safely and as quickly as possible is ultimately going to be their most defining treatment, because there's a multitude of things that are done within the hospital setting that we're unable to support with, including, you know, the basic antihypertensive therapies. We don't carry any standard antihypertensives, but magnesium, though its purpose isn't to actually reduce the blood pressure, often does have that nice side effect of managing to do that. So I think that's it from me on preeclampsia and eclampsia. Again, happy to take any questions as we move forward. But I'll hand over back to you, Camilla.
Thank you so much. And thank you, Joanna and Kerry, for that brilliant presentation. So I'm just going to get everyone, all the presenters, to spotlight themselves. And while we're doing that, I'll just move us to the next slide. So what you'll notice in JRCALC is that we've tried to make a few more things consistent. So, for example, around the conveyance of women and babies. So if they're pregnant, they can be left or right lateral. If in most UK ambulances, if they're right lateral, then they will be able to still communicate with the crew. So right or left is completely fine, and babies do need to be secure. So if you want to look up more information around that, that's in the labour and imminent birth guideline. So that was just a reminder around that. So please now go to the Q&A at the top of your screen and put in any questions about any maternity guidance, maternity and newborn care guidance on JRCALC. Because here on the webinar today, you have you have authors from all of the guidelines, and we'll be able to answer your questions and give you any rationale that you need. So please use the Q&A, and if you can just vote as well on your questions that you'd like answered, then that really helps us just to prioritise them if we get lots coming in. So I'm just going to have a quick look here. So the first question is for you, Dawn. So for a recent baby, I went to full-term, rapid labour, meconium in the waters. By the time I had arrived, baby was a little cold after doing skin-to-skin with parent. Baby was warmed with transwarmer and then dressed as per parental wishes once temperature come up. Is it better to keep undressed on top of the transwarmer, then in all the blankets, or is it okay to dress, then transwarmer and all the blankets once temperatures come up again for transport?
I didn't quite get the end of that. I don't know if that's your signal or mine, but I get the gist of it. So I think Rob and I discussed this actually, and we've decided that you keep the baby warm, don't interrupt that warming inside the burrito. So keep the baby on the transwarmer, keep them burritoed and get them to hospital. We completely understand that the parents want the baby dressed, and we can do that when we get to hospital, but prioritising thermal care and keeping the baby warm and alive is more important than putting clothes on. So hope that answers your question.
Thanks so much, Dawn. The next question is for Stacey, please. So if you arrive to a maternal arrest as a crew, would you prioritise someone manually displacing the uterus with the other person trying to do pads, stroke CPR, stroke BVM, or normal algorithm until more resources arrive? So
yeah. Thanks, Cam. Yeah, that's a really good question. So we would very much, what we've tried to adopt within JRCALC is very much what they've said within the ERC, so European Resource Council, and they've highlighted that it's a case for manual uterine displacement when there are 2 or more clinicians available. So one would be as soon as possible carrying out manual uterine displacement whilst the other clinician establishes CPR. So obviously that would mean, as you would do if you were a solo responder in a standard adult ALS situation of applying the defib pads and then doing chest compressions until more resources arrive. So we would say keep it as simultaneous as possible, but if there's just a two-man crew, one clinician goes straight to manual uterine displacement and the other clinician would apply the defib pads and start chest compressions. I think if you don't mind me just making a note as far as that's concerned, it wasn't necessarily in our presentation, but just a reminder that chest compressions, it's good quality chest compressions with hand placement, the same as standard adult ALS management with hand placement. And the defib pads, you might have to find that you'll have to manually move a woman's breast if she has large breast tissues that will occur during pregnancy. So again, making sure they're done effectively. You're not laying a defib pad over breast tissue and you haven't changed your hand position. And then the other clinician would do manual uterine displacement.
Thank you very much. And I think just following up on that, we've got a contribution from one of the attendees saying crucifix ALS head and can pad CPR, iGel and IO, while the other displaces, works well with previous experience. So I don't know if you want to comment on that, Stacey or Steve. I think they're basically saying similar to what you've just said, Stacey. Okay. I think.
Okay.
Yeah.
Thank you. Sorry, I'm just catching up with the with the Q&A. So great. Yeah. Thank you.
Cool. Thanks very much. Kerry, shall I come to you on this? So the question is, with a patient that's within 4 weeks of birth and hits the red symptoms, are we going to resus or maternity unit?
Thank you, Cam. So largely we say follow your local guidance because there will be variations between regions. But I think as a cumulative team, we do largely agree that if there's an immediate A or B compromise with that mother, then probably the ED department. But more than anything else, it's about having that clear communication with maternity or the emergency department about where you are going. So we largely don't mind where you go, as long as everybody is ready to receive you on your arrival and that you all turn up in the same place at the same time. So just that closed loop communication. Okay, so just to confirm, you want me to meet you in the emergency department. Can you let the emergency department know that we are coming down to them, and that is where we'll meet you? So just to reaffirm, it's the emergency department that we're going to. They're going to be those few extra words that make all the difference in those really time critical situations. I'm getting nods, so I'm going to go with that's the consensus of the group.
Thanks very much, Kerry. So Steph, can I come to you with this one? So on a 28+2 sudden delivery in the community, I asked the question to the 2 crews present: are we setting up a resuscitation area or are we moving? My colleagues looked at me with horror and said, "We're obviously we are moving." Statement. I thought it was a sensible question to ask to make sure we're all on the same page. What are your thoughts? And just to say that they've met the baby and dad 6 months later and everyone's doing well. So that's brilliant work, everybody involved in that case. So yeah, Steph, your thoughts on, I guess, staying or leaving in these situations and whether that's a good question to ask.
Yeah, perfect. Definitely a good question to ask so that the whole team are on the same page and we know what's happening. If we look at the imminent birth JRCALC algorithm, that will help us decide whether we are classing this birth as imminent or not. So imminent birth is classed as contracting and the urge to push, or you can see the top of the baby's head. I think regardless of gestation, if that birth is imminent, we could argue that the safest thing to do is deliver that baby where we are, stabilize mum and baby, and then transfer, if everyone agrees with that. But if birth is not imminent, then absolutely. If she's only contracting but has no urge to push, or you can't see the top of the baby's head, a time critical conveyance to your nearest maternity unit is absolutely the right thing to do. But we can't ignore imminent birth is if it is ticking those points on the definition of contracting and the urge to push. Just to say that as well, we need to make sure we're doing that continuous 10-minute assessment. If you don't have any progress within a 10-minute period, then you can change your decision making and change it to transportation rather than staying on scene.
Thanks so much, Steph. It's a question for you, Rob. So for a baby born under 32 weeks, if a truss does not have a transformer, do we still put the baby in plastic, not dried?
It's a good question. My answer would be get some transformers, or other mattresses are available, because they're great. They're a really handy bit of kit. The plastic bags themselves have no insulating properties. So without an external heat source, the plastic bags don't add anything in themselves. But it's the sort of situation where it's difficult because, as Dawn said, these babies are not great at producing their own heat. So if you absolutely have no recourse to a heat source, then what I would suggest is you dry the baby. You can put them dry into the bag, and that will stop a little bit of water loss. And then improvise as best you can with a heat source. So if mum's cold and a bit shut down and not looking well, a dad or a partner would be an alternative to provide some heat through skin to skin, covered properly, as Dawn said, with potentially towels over the baby in the plastic bag next to someone's chest, and a hat on is key. But the devices are becoming more accessible, more affordable than they used to be. So if you're able to, I would go back and speak to whoever your stock people are and see if you can get some. Hope that helps.
Thanks very much, Rob. Steve, the question is, if you're a lone worker, how do you manage manual uterine displacement in cardiac arrest?
Oh, I knew I'd get this one. So as a lone worker, managing, I'll try to find the question. What was the question again? I've lost it.
It's about if you're a lone worker, how do you manage manual uterine displacement in cardiac arrest?
Right. Okay. Yeah. So if you're a solo responder, there's at any cardiac arrest, but cardiac arrest in pregnancy, there's 3 things you need to do: effective chest compressions, effective airway and ventilation, and manual uterine displacement. Unfortunately, you can't do all 3 simultaneously, so we're going to have to prioritize. I think probably the most important thing you can do is call for help, get some help there, get some support there. And it's kind of work it as a case-by-case situation. I think CPR compressions is probably the most, is the highest in the priority of over chest compressions or manual uterine displacement. Chest compressions are probably the highest priority because although it's still going to be less effective, it still produces some cardiac output. It still buys some time. I think in this situation, it's not an ideal situation, but it's going to be suboptimal CPR, and suboptimal CPR is far better than no CPR. So I think that's probably the workaround.
Thank you very much. Let's hope no one's ever in that situation. Can I ask you, Kerry, a question? So when considering midazolam stroke diazepam in eclamptic seizures, how long would you hold off administering to wait for a critical care paramedic to arrive to give the magnesium instead? Oh, you're on mute, Kerry.
Clicked it twice. I was too efficient. So it's a nice easy one actually. We would give midazolam and diazepam in line with the standard JRCALC guidance. So for the most part, we don't expect eclamptic seizures to happen as a cluster. They occasionally can, but it's rarely that we tend to see it. So if you still have your same indications that you would have for your midazolam or your diazepam, so your seizure lasting 5 minutes or more, or 2 or more seizures without a full recovery in between, would be your indication to give your diazomols. We treat all unpredicted kind of seizures in pregnancy as preeclampsia until proven otherwise, but it's, you know, there are other reasons for people to have seizures, so it's about kind of that balance in those situations. But yeah, just follow your standard indications as per JRCALC.
Thanks very much, Kerry. And it's kind of a follow-up question, I guess. I don't know if you and Joanna want to jointly answer. In an eclamptic woman fitting, if a doctor is close proximity, e.g. minutes away, is it better to wait to administer the magnesium, or should we go ahead with benzos? I'm imagining this is a situation where they don't have magnesium.
Shall I say something and then you can say the opposite, Kerry? Or I guess from my perspective, of course, we're going to individualise the care, and it depends what we mean, I suppose, by minutes away. But and I think if your normal protocol for giving benzodiazepine would be to give it, I would, because a couple of minutes away might end up being 10 or 20 minutes away in the sort of way life can be, and there would be. When the doctor arrives, they could still go on and give them magnesium, even if she had recently had benzodiazepine. So I think that's what I would say. Do what you'd normally do. And then when the next person arrives, they can do what they would normally do. And get her to the hospital, please, as soon as you safely can. Are we in agreement, Kerry?
We are. I'm nodding.
Marvellous.
Much nodding.
Great. Thank you. Dawn, I'm going to give you this one, if that's all right. So it's a preeclamptic patient with stroke symptoms. Which hospital is the most appropriate? Would you take to a stroke unit or a maternity unit? And what if these units are in different hospitals?
Oh, thanks for this question. That's evil. I'm going to my nearest stroke unit. I'm going to look to Kerry, though, to see if she disagrees or agrees.
No, I agree. They'll have magnesium in the stroke unit. But we won't necessarily have the resources to manage a stroke patient in the maternity unit. It's all about that simple question of, essentially, to put it quite crassly, and I do apologise because I can't find better words, what's going to kill her first? And the stroke will kill her before the eclampsia does, and they will manage the hypertension as part of managing the stroke. So do I get a nod from the obstetrician?
Well,
yeah,
can I sort of nod and shake my head at the same time?
Yeah.
Obviously, different parts of the country have different geography, don't they? And I suppose, yeah, I'm based in London, and that's the geography I know. And I do agree with what you've both said. But hopefully, the maternal medicine network for the region where you're practicing has thought about this beforehand. And if the hyperacute stroke unit is not co-located with maternity, then hopefully there is a clear pathway that has been shared with you, or you've been involved in developing, or maybe you could do that, to actually pre-decide what those might be. So am I allowed to name hospitals? Use London, Northwest London as an example. We've got 2 hyperacute stroke units. We've got Charing Cross, which is marvellous, but no maternity, and we've got Northwich Park, which is also marvellous and does have maternity. And then to make things complicated, we've also got some areas where they do some of the stroke work, and they're all within about 10 miles of each other. And so we hopefully have a process where mother and baby can go to the one that will provide all the care. Now, I appreciate in many parts of the UK that might be really different, but I think if you are all knowing that your stroke unit and your maternity unit are not co-located, it'd be really good to talk to your maternal medicine network leads just to see what planning could be made for this rare but important event.
Just to add to that, sorry, one last thing. I think this is about shared decision making. This isn't about unilateral decision making. And I would be contacting my critical care desk and as many senior clinicians as I could to share this decision, because this is not an easy one.
Yeah, agree.
Absolutely. Thank you very much, all of you, for that very comprehensive joint answer. It was awesome. Bethan, I'm going to come to you with this one. So the person is saying food for thought. There's a previous case that they were involved with. So the crew, they have stayed with mum post resuscitative hysterotomy as they were closing the surgical wound, and it was a difficult extrication. But the newborn was in arrest, and they had got ROSC on the newborn and was easy to take to hospital, or easier than the mum to take to hospital. And there was a challenge when the baby arrived at hospital without mum, regarding paperwork and registration. So I guess it's this thing about when a crew arrives on at a maternity setting with a baby without a mum, and our thoughts around that and whether the crew have done the right thing there.
So first of all, great question, and really I think outlines the complexities of the pre-hospital setting and what our clinicians have to deal with. So we've got 2 obstetric emergencies here. You've done the right thing in the dynamic risk assessment and taking baby as that was an easier extrication. So when you arrive at the hospital, an early pre-alert to say the baby is arriving without mother, given clear mother's details, mother's date of birth, address, and full name. And if that mother has booked her pregnancy, if she hasn't, it probably adds another layer of complexity to it. But if she has booked her pregnancy, there should be a system that the hospital can access that will identify that baby to that mother. But we have to be really sure that the mother's details are correct when conveying to the unit. Yeah, I think that covers it. Has anyone else got anything to add there?
I would just add, Beth, exactly that. And I think, Rob would be, the doctor on the call that would just assure us that it won't delay care, the baby arriving and him meeting the baby down in the ED department. The care won't be delayed as a result of not having much maternal information. Yes, it would be very nice as far as registering that baby and knowing the mum's NHS number, but they're not going to delay care as a result of that.
Exactly.
Rob, do you want to speak to that from a thermal regulator, keeping the baby warm perspective?
So in terms of getting that baby to hospital, if you've got a maternal arrest, it puts the baby at very high risk of significant neurological damage. So the key thing here is time to therapeutic hypothermia. So we will obviously say to you guys, normothermia is your aim. Keep it normothermic, measure your temperature, adjust your thermal adjuncts as possible. But getting that baby to hospital quickly is the quickest way to get it onto the right monitoring, or potentially it might need an uplift to a neonatal intensive care settings. And there is a window of opportunity, which is somewhere between 3 and 6 hours, to start and get to a therapeutic temperature to have best effect in terms of preventing secondary injury. So time is of the essence for that baby. I would say that crew sound like they've done a great job, and I'm really sorry my colleagues sometimes are idiots.
Thank you. Yeah, well said. I know that us as the National Pre-Hospital Maternity and Newborn Care Leads Group, we are really trying to strengthen the way that you're received in hospitals when you're bringing in perinatal patients or newborns, because we realise that you often experience incivility and poor reception. Please pop any more Q&A questions in the Q&A if you have any. I believe that we have answered all of those that are there already. Whilst you're doing that, if you want to, just a reminder that you will be sent the evaluation link and a certificate. So please fill it in, because we are, I think, with the only subgroup of AACE, the JRCALC guidance body that does these national webinars following maternity, following guideline updates. And so it'd be really helpful to understand how helpful these sessions are, and whether other patient group guidelines could benefit from a similar format of disseminating information. Also, just a reminder that anything you didn't know at the beginning of this webinar is something that another ambulance clinician might not know. So if everyone on this call tells 10 people that learning point, then we'll spread the information to more than 3,000 people, which will be a good impact across the UK. So please take away as many learning points as you can and spread them to at least 10 people in the next week if you can. Just a massive thank you as well to all the speakers and the panelists here. You're all amazing, and thank you to everyone who contributes to the JRCALC guidelines for maternity and newborn care. Lots of it is done in our own time and with many conversations to try and get these as good as we can. So thank you to everyone that's been involved, and hopefully it's been helpful hearing from the authors today. Is there anything else anyone wants to add? Because the last thing I just wanted to say was thank you to everyone who's attended. Over 300 people came today, and we realised that you're all really busy people and it's really hot and you could be enjoying the sunshine, but you've come along today. So we really appreciate that. So I'm just going to pop up the, you can fill in the evaluation form there, and that's where you can access. Oh, sorry.
Pam, it's only me. I was just going to add that although the group has worked very hard in updating these guidelines, we really are open to you feeding back through the maternity leads in your ambulance services if you feel there's any improvements that can continuously be made. So please feel free to feed back to us as a group. We're very open to suggestions and continuously improving those guidance.
Yeah, absolutely. That's the way that we've refined them so far, is through feedback from crews and from patients. So yeah, absolutely help us to shape them in the future. And the recording will be available on that YouTube handle. If you subscribe to the channel, then you can get all of the updates and videos that we do if you haven't accessed them already. Thank you so much, everyone, and particular thanks to all the speakers. Have a great rest of your day.
Bye, everyone.
Oh, Victoria, do you have a question? Put your hand up.